Hello, welcome to this instructional video where I will demonstrate how to properly perform a head and neck physical exam. The inspection process of your patient should begin at the first site, where you will have the opportunity to appraise your patient's general appearance and locomotion. During the medical history interview, you can evaluate your patient from a cognitive standpoint, for example, if the patient can answer your questions accurately. During this time, you can also assess your patient from a neurological standpoint, if the patient is alert and oriented to person, place, and time, or if the patient has any neurological deficiencies like facial palsy, any facial asymmetry, or obvious skin lesions. Before starting performing the head and neck exam, make sure you have recorded all the pertinent vital signs. A comprehensive extraoral and intraoral examination should be performed systematically to minimize oversights. For the extraoral examination, place your patient in a reclining position and follow a logical sequence, starting from top to bottom. Start your exam inspecting your patient's head by palpating the scalp, searching for possible lesions hidden in the hair. Continue your exam by placing your fingers on both sides of the head to palpate the temporalis muscle. The temporalis muscle is a bilateral masticatory muscle that extends posteriorly and covers a large area of the head. You can assess it through firm palpation. Asking your patient to clench will help you to localize the anterior portion of the temporalis muscle. During the temporalis palpation, you can ask your patient if they feel any pain or discomfort. Continue your exam by assessing the TMJ. Place your fingers in the preauricular area to evaluate the TMJ capsule. Apply light pressure and ask the patient if they have any pain or discomfort. Then, ask your patient to slowly open and close their mouth 3 times while you look for limitations in the range of motion, deviations, or deflections. Also, during this maneuver, you can hear the TMJ clicking, popping, or crepitus. Continue going down to assess the masseter muscle. The masseter muscle is another masticatory muscle that we can assess through palpation. Asking your patient to clench will help you to localize the superficial masseter muscle. The neck examination follows the sequence. Turn your patient head to the left to expose the sternocleidomastoid muscle. Identifying the sternocleidomastoid muscle will help you to localize the superficial cervical lymph node that lies posterior to the sternocleidomastoid muscle, and the anterior cervical lymph nodes that lies anterior to the sternocleidomastoid muscle. You can also grab the muscle and ask your patient for pain or discomfort. While the patient is in this position, you can also palpate the occipital and mastoid lymph nodes and inspect the postauricular area looking for skin lesions that could be hidden. To finish, do a quick palpation of the muscle of the neck and repeat the same process in the contralateral side. Continue the neck examination by localizing the laryngeal prominence of the thyroid cartilage, also known as Adam's apple, that is typically more prominent in males than females. Bilateral, in a butterfly shape, you will find the thyroid gland. You can move the larynx side to side and also palpate the thyroid gland, searching for enlargement or nodules. You can ask your patient to swallow, and you should see a uniform up and down movement of all neck structures. The palpation of the submandibular nodes follow. Approach from behind the patient's head and identify the inferior border of the body of the mandible, and place your fingers in the submandibular area. Ask your patient to lower the chin and gently but firmly press the skin of the submandibular region against the mandible, and roll the tissue bilaterally under the inferior border of the body of the mandible. The submandibular lymph nodes are the only lymph nodes in the head and neck region that you can typically palpate as a normal finding. They should feel soft, movable, non-tender, and less than 1 centimeter. To complete the intraoral exam, pay attention to the nasolabial and labiomental groups. The intraoral soft tissue exam begins with a lip examination. First, note color, contour, and the texture of the unopened lips. Note that at the corners of the mouth, the labial commissure presents folds. Identify the lever tubercle, a bulbous enlargement projecting inferiorly in the center of the upper lip. The lips are transition zones between the skin and mucosa. The red surface of the lips is often referred as the vermilion. Measuring a centimeter or wider, the vermilion is characterized by blood vessels very near to the surface and the lack of sebaceous glands, which makes the area susceptible to drying. Look for changes in color, texture, or surface integrity, some of the first signs of lip cancer. Grasp the lip and palpate to determine if variation exists in the consistency of the tissue. With the help of the mirror, stretch the cheek and inspect the whole surface of the vocal mucosa. At the level of the maxillary second molar, you can see the opening of the parotid duct at the parotid papilla. Also, some patients might have linea alba, a horizontal ridge of keratinized tissue extending along the line of occlusion of the teeth. It is very common to find tiny yellowish white spots that sometimes occur in clusters. These formations are known as 4-dye granules and represents ectopic sebaceous glands. In your transition to the other side, check the oral vestibule, a U-shaped cleft-like space bound by the lips, labial vestibule, and cheeks, buccal vestibule, externally, and by the teeth, gums, and alveolar process internally. After the visual inspection, palpate the maxillar and mandibular vestibules, searching for changes in the topography or consistency of the vestibule that could indicate the presence of pathology. Then, direct your attention to the mucosa of the labial and buccal portions of the oral vestibule. Note a fold of mucous membrane, the lip frenulum, which attaches the lips to the alveolar process. The inspection of the palate follows. Using the mirror for indirect vision and lighting, visualize the entire palate. Note the mucosa of the hard palate is typically pale pink, resembling gingiva. Palpate over the hard palate with your index finger. Locate the thin, light line marking the middle line of the palate. This is the palatine raphe and is sometimes elevated, especially anteriorly. Locate on the mucosal surface of the hard palate a series of irregular ridges called transversal palatine folds or palatine ruga. Find a small round elevation, the incisive papilla, immediately posterior to the maxillary central incisors. Verify that the lateral aspects of the hard palate is softer and more compressible than the one near to the midline, especially posteriorly where we can find the greater palatine foramen. On either side of the palatine raphe, near to the posterior border of the hard palate, look for a shallow indentation in the palatine surface, called the palatine fovea, into which ducts of some of the palatine ducts empty. The soft palate is covered by a thin, darker red mucosa, and you can clinically differentiate it from the hard palate, locating the vibrating line by having the patient saying ah. Use the mirror to gently but firmly depress the tongue, and while having the patient saying ah, you can in few seconds inspect the oropharynx. Identify the uvula, projecting posteriorly and inferiorly in the middle of the free border of the soft palate. Verify that the uvula hangs in the middle at rest. Identify the palatoglossal arches that marks the actual boundary between the mouth and the pharynx. Behind the palatoglossal arches, you can localize the glossopharyngeal arches. These two structures create the tonsillar fossa that contains the palatine tonsils. Then, grab a strip of gauze around the anterior 1/3 of the tongue and hold it so you can manually move it. Pull the tongue gently to one side to better visualize the entire lateral border. With your free hand, palpate along the entire lateral border and the dorsal surface. While holding the tongue with the gauze, use the mirror to visualize the posterior ventral tongue and the floor of the mouth. To examine the floor of the mouth, ask the patient to put the tip of the tongue up to the roof of their mouth. Identify the lingual frenulum, a thin, median mucosal fold by which the undersurface of the free portion of the tongue is anchored to the floor of the mouth. On either side of the frenulum, near its attachment to the floor of the mouth than to the tongue, locate the sublingual caruncle, a small conical projection with an opening at its apex that represents the opening of the submandibular salivary gland. Use a bimanual technique to palpate the floor of the mouth, with one finger in the mouth pressing against finger of the other hand on the chin. Distinguish its most substantial component, the myohyaline muscle. Move your fingers along the attachment of this muscle to the inner surface of the mandible. A thorough oral examination concludes with the evaluation of the dentition, including the supporting structures and the analysis of the occlusion. All findings should be recorded in your medical history. Have in mind that every patient is different and they will present with variation of normals that you will learn how to identify and what they represent. With a little bit of practice and patience, you will master the technique.